Thank you to CardiapCon for the kind invitation to talk about DeEscalation of antiplatelet therapy in coronary patients. Is it time to change our strategy? These are my disclosures. We have new data about dual antiplatelet therapy and single antiplatelet therapy. As you know, for the guidelines, the European guidelines, you have many options with several duration and several options in the choice of antiplatelet therapy, and especially in P12 inhibitor. So as you know, the main issue in the dual antiplatelet therapy with high intensity is associated with a less recurrent events in ischemic events, but also in an increase of bleeding risk, especially major bleeding risk. As the ischemic events decrease during the first month, the bleeding events remains high during the follow-up. You have many options, maybe too many options, so it's very useful to know what is the best strategy actually according to recent data. The rationale to let aspirin, who was the gold standard for many years, and that P2Y12 inhibitors in monotherapy are effective, safe. They led the same rates of ischemic events with a decrease of major bleeding events, especially after the first 3 months, and they are synergistic effective effect. So the main issue is to evaluate the criteria of major bleeding, and we have frailty, for example, for patients with triple association, you have an increase of major bleeding. So in this case, you have to use very quickly after 1 week a single antiplatelet therapy. Also for patients with thrombocytopenia, also for patients with chronic kidney disease or liver cirrhosis, is very useful to decrease rapidly the dual antiplatelet therapy and to switch to monotherapy. We have performed, thanks to the team of Philadelphia with Wakasola, we have performed a meta-analysis to see what is the best DeEscalation according to every data available in randomized clinical trials and also in registries. As you may see, the best strategy is the DeEscalation in terms of risk benefits between reduction of ischemic events and avoiding major bleeding. And the best benefit is a short duration of DAPT with switching with a P2Y inhibitor, P2Y12 inhibitor. So the current strategy should take into account many factors to have a personalized approach in antiplatelet strategy. You should consider the clinical variables of patients. Is it an acute coronary syndrome? Is the patient diabetic? Is it elderly? Do you have a global frailty, chronic kidney disease? Do you have recurrent ischemic events or bleeding events during the follow-up? Do you have to use platelet function testing? I think that platelet function testing are not very useful as we have many negative trials. But genetic testing may be useful if you have to switch to clopidogrel, but it's rarely performed in practice. You may also use scores for bleeding risk to guide your single antiplatelet therapy. And you should also use a score for ischemic events. Is it a polyvascular disease? Do you have many stents? The length of stents to decide what is the best strategy. In conclusion, the gold standard for many years was high-intensity dual antiplatelet therapy. We know that acute coronary syndrome patients remain with a high residual risk of major events, ischemic events, but you have to deal with the overlap between ischemic events and bleeding risk factors such as chronic kidney disease and age, for example. And for the DAPT strategy, one size clearly doesn't fit all, so you have to personalize your approach according to several factors, coronary factors, but also clinical factors and events during the follow-up. But as you know, according to all the recent data, DAPT DeEscalation is a strong trend supported by many data, also meta-analysis. As for many patients, for most patients, you have no excess of ischemic events after you switch to a single antiplatelet therapy at 3 months for a majority of patients. And it's very useful only you can use the single antiplatelet therapy is the control of risk factor is suboptimal. Optimal, that means smoking cessation, a glycated hemoglobin very low, using GLP-1 receptor agonists if they are available, and a very low LDL cholesterol below 55 milligram per deciliter, as the optimal level seems to be 30 milligram per deciliter. A better implementation of guidelines is needed, as many patients remain with long-term DAPT without a high level of proof. And obviously, a global and collaborative approach allows to reach and maintain goals for these complex patients. Thank you to all co-authors of our article available on European Internal Journal of Medicine. Thank you to CardioDAB for the kind invitation.